Well, hello. Welcome everyone who has joined us so far. We are excited to have today our fourth virtual meeting with the Mid-South MGMA. We definitely are missing the wonderful luncheons at Chickasaw and excited to hopefully start that back here soon, but obviously a lot going on in the world today with COVID and the medical groups that we're representing today, and excited to have some great speakers to talk to us about some very relevant matters that hit home very much here in Memphis area. Real quick, today's meeting is sponsored by MedTemps and the Medical Society. With that, Clint, if I'd like to let you talk a little bit about that.
Thanks, Eric, and excited to be the guinea pig sponsor for a MGMA lunch. This is obviously an opportunity we hope more of our affiliate members will take advantage of. So a little bit about the Medical Society and MedTemps for those that may not know. MedTemps, of course, is your staffing source. We can staff any position in a medical practice. We can staff temp to perm, permanent, and simply temporary needs. We try to make our pricing really fair, as majority of our customers are members of the Medical Society, and we like to keep that pricing fair and provide that as a service to our members and the entire medical community. So always excited to take your calls and emails about that. As you can see on the screen, you can go to our website and learn more. Most everybody knows our phone number and how to get in touch with our staff, so feel free to reach out on that. I wanted to take the opportunity as well to make sure you all were aware of a new program that the Medical Society is offering called Thrive. To make a complicated situation short, Thrive is basically a wellness hotline for physicians who are experiencing symptoms of burnout. So I encourage our medical group managers out there, or even some of our affiliates, if you have a friend or colleague who's a physician and you feel like they're struggling, encourage them to call or access the website to get more information about our hotline. Those calls are strictly confidential. We have one person that answers those calls and then routes the individual through our telehealth platform, which is provided by CareClicks, telemedicine vendor that we've been working with. So we're excited to offer that. The best part about the program is that the Medical Society pays for the appointments for those physicians who access the hotline. The first 6 appointments are on us. We've actually had some people access the hotline already. A lot of mixed emotions around that. It means you're providing a service, but it means people are out there struggling. And we want to make sure that, again, that we're a confidential source out there for them. So just go to our website to learn more. And Eric, I really appreciate the time today, and I'll turn it back over to you and Adriana for our speakers.
Thank you, Clint. Appreciate that. And yes, without further ado, Adriana, let you introduce our speakers today.
Absolutely. Thanks everybody for coming and sharing your lunch break with us. We're really excited to introduce these 2 speakers. I had the opportunity to hear them speak last year, and they just knocked it out of the park. And like Eric said, this is an extremely relevant topic. Even in the midst of a pandemic, just remembering that other people are struggling with things other than just COVID, and opioid addiction is one of them. So just to tell you a little bit about Jill and Josh. Jill Carney, she's a regional overdose prevention specialist for the Memphis Area Prevention Coalition. She graduated from the University of Idaho with her bachelor's in psychology, and then she went on to become a registered nurse. Along with Josh, since 2016, she's helped distribute over 14,000 units of Narcan to the Shelby County community, which is awesome. And then Josh, he's a regional overdose prevention specialist as well with the Memphis Area Prevention Coalition. Josh has been involved in Shelby County recovery community since 2001 and is in recovery for alcohol and opioid addiction himself. He received his Bachelor's of Science in Nursing from the University of Memphis in 2011 and is a registered nurse in the state of Tennessee. Welcome, guys. We're excited to hear your presentation. And just to let everyone know as well, sorry, if you're interested in getting your own Narcan kit, I'll have those at the Memphis Medical Society for distribution, or you can let myself or Eric or Clint know, and we can get them to you personally. All right, all you guys, thank you.
They'll be there tomorrow after 12, by the way.
All right, are we ready? All right, like she said, we are regional overdose prevention specialists for Shelby County. We work for the Tennessee Department of Mental Health and Substance Abuse Services through, sorry, trying to get my PowerPoint up, the Memphis Area Prevention Coalition. And we are a branch of Church Health. So basically we don't know who we work for, but
We work for a lot of people.
yeah, we know what we're supposed to do. And talking about this pandemic, so, you know, the overdose crisis was already a pandemic. And when the pandemic hit, yeah, well, sorry, my screen is, when the pandemic hit, we saw a surge in overdoses like we've never seen before. Overdose fatalities in Shelby County went up 65%. And, you know, we're still, it's gone down a little bit. We put a lot of efforts into getting Narcan to the high impact areas, but it's still on track to, we're going to see numbers this year like we've never seen before. And part of it is the stimulus money coming in. Access to recovery communities was shut down. People were kind of forced into isolation, which is never good in a recovery setting. So we have kind of the perfect storm and all these things going on. And what we saw was a huge increase in overdose deaths in Shelby County. So, you know, we've kind of got two pandemics going on at once.
That's absolutely true.
And what we do as ROPES is that ROPES is short for Regional Overdose Prevention Specialist, is we educate on stigma, science of addiction, and train people how to use naloxone. And, you know, our main function is to train for naloxone and get it out to people in the Shelby County area. There's 22 of us across the state, and Jill and I cover Shelby County. We've gotten all law enforcement trained, treatment centers, halfway houses, anyone involved in the recovery community, any medical facility really, places where people overdose. There's convenience stores, Kroger parking lots. You know, the Surgeon General has said that everyone should have Narcan. So, you know, basically that's what we're trying to do. We train facilities as agencies, and then they can keep Narcan and divvy it out to their clients. So when someone leaves AMA or tests dirty on a drug test, anything like that, they can get a Narcan kit and take it with them. And that's the idea, is to get these kits into the hands of people that are high risk. Not to, you know, have it on the premises and wait for someone to overdose in your bathroom. You know, it's much more likely to be used if it leaves with the person that might overdose.
And we, you know, if any of you guys would like to have it for your agency, we are happy to come and train as well. That is what we do. So, but like you said, the Surgeon General said every family should have it alongside their first aid kit in their own homes. So that's a pretty big statement.
Yeah, and we'll talk about what those numbers look like throughout the training. I'm going to talk a little bit about the stigma, science of addiction, things like that. You know, what's really going on behind the behavior. And then Jill is going to do the actual Narcan training. So what we do as a coalition is harm reduction. And I'm sure you all are familiar with this process, and it's meeting people where they're at. And this is especially important with alcoholism and addiction, because it is very difficult to come in contact with a person when they are ready to get some help. So in the meantime, we're trying to prevent HIV, hepatitis C, endocarditis, death, of course, from overdose. So the kind of programs we run are the Narcan program. We do have a needle exchange, which is relatively new for Shelby County. We're a couple of years behind the other counties. And generally, you know, studies have shown that new cases of HIV were reduced by 70% in areas like DC and New York when they began the needle exchanges. And that, of course, is new cases within the IV population. And Shelby County right now has about 6 times its normal rate of HIV going on. We have the highest HIV rate in the country here. So hopefully, you know, now that we are operating a needle exchange, we will see that number go down. But we also offer Narcan to everyone who comes, and it's also a place for them to go when they are ready to get help. We have access to treatment, things like that. So that's just part of our program. Yeah, we've gotten a lot of people into treatment. It's kind of a doorway for that. But that's the idea of harm reduction, and this is all you know, best practices. This has all been shown to work, and there is data that shows reduction in death, reduction in HIV and hepatitis C, and an increase in people going to get treatment. So reducing stigma is one of the big ones. You know, and the stigma goes up, way up to high levels. In Tennessee, or actually it's a federal law, I believe, that we cannot spend the dollars we get for the needle exchange on needles. Because, and the reason behind that is they don't want to buy anything that will help someone do drugs. So even though the massive amount of money that will be saved from medical bills and things like that needle exchanges have shown to change, we still have stigma at that high of a level where we have to go for donations, you know, to get things like that. And, you know, the stigma is with addiction, substance use disorder, people tend to look at the behavior and don't understand what's going on behind that behavior. And they say person first language. In other words, we look at the human being first, and it is a human being with a disease, not, you know, Bob the junkie, or, you know, if somebody has cancer or diabetes, we don't call them by the name of their disease. We call them their name, and they have this disease. And it tends to go the other way with addiction. So, you know, and this falls on a continuum. It is a very progressive disease, and it kind of depends on where that person is at on that spectrum. And relapse is looked at as a moral failure. This is not a moral issue. There are, you know, biochemical components, mental components to this disease, and we'll discuss that a little bit. But it's looked at that way because it appears that that person is making really bad choices. And, you know, the truth is that person is being run by something that is bigger than them. And 40 to 60% of people will relapse at least one time throughout their recovery. And, you know, especially in the medical field, we have to be aware of unintentional personal bias when we are dealing with someone that has substance use disorder. And addiction is a chronic disease, so it does change the brain structures and functions. There are genetic components, there's predispositions to this disease. I'm going to stay on this slide for a second and kind of talk about what we have learned over the past 80 years or so. You know, this was classified as a disease by the American Medical Association in 1956. So, you know, research back then, it pointed towards it, and we've had so much more now, and we have a lot better understanding of what's going on in the brain with people with substance use disorder. So back in 1959, 2 doctors did an experiment on mice and rats, and they inbred the mice and rats for 20 generations. And what they did was create groups of mice and rat that were genetically identical, about 98.5% identical. And they made alcohol and drugs available to the groups. And what they saw was that some of the groups, the whole group, would go back for the drugs and alcohol over and over again, and some of the other groups would just leave it alone completely. So they determined that there was a genetic component or some kind of predisposition to addiction. Since then, we've done the Human Genome Project. We know now there's about 90 genes associated with alcoholism and addiction. It is not a single gene that says whether you're an alcoholic or an addict, but it is a combination of those genes seen in almost every case of substance use disorder. And what these genes determine is pleasure response in the pleasure center of the brain. It determines how tightly a substance attaches to the receptor. It determines receptor sensitivity. And all of those things, you know, what that manifests as is that person who becomes addicted to whatever the substance is has a completely different experience than a person who doesn't. So opiates are a great example. 8 or 9 out of 10 people will go get an opiate from a doctor. They will take that opiate and it will do exactly what it's supposed to do. It will kill the pain, but it will be an unpleasant experience. It will be, you know, they get groggy, stomach might hurt a little bit. They take it till the pain is gone and then stop taking it. Well, with that 1 or 2 people out of 10, they take it and they have a completely different experience. They get a heightened sense of euphoria, extra energy. With some people, you know, people that have other mental issues in particular, trauma, depression, someone that's painfully shy or has a nervous disposition, that person takes that substance and gets that response. It is a revelation to that person. I call it the Jerry Maguire moment. You complete me. That's what it feels like. Why haven't I felt like this all my life? It solves all those problems. You know, there's a lot of people, you know, billions of dollars a year on antidepressants and anxiety medications. All of those people don't become alcoholics and addicts because they don't get the same effect from that medication or that substance as the person who is predisposed to it. So does that alone make a person have substance use disorder or addiction? Of course not. What it does is it makes that person more likely to continue using that substance. And this is where the problem occurs. So because they have an elevated pleasure response from this substance, the rest of the functions of the brain are elevated as well. And, you know, we talk about dopamine a lot. And dopamine is associated with addiction because it's seen in every single addiction in very large amounts being released. And, you know, it turns out, so they used to think dopamine was causing the pleasure or associated it to the pleasure. And since then, we found out what dopamine does is it gives someone motivation to certain behaviors. And it is mostly associated with survival. So, you know, things like food and sex and companionship, things that are good for procreation and to ensure the survival of the human race, our brain is wired to have us continue to do those things. So we get dopamine released, and what dopamine causes is a want or a craving. You know, it's not something that is well thought out or planned out. It's a craving. And a good example, sugar releases a lot of dopamine. You know, sugar is instant energy, stored energy. It's good for survival. We have a big dopamine response to sugar. So if any of you have ever tried to go on a diet, today I'm just going to have chicken and rice and nothing else, and then by 12 o'clock in the afternoon, you have a chocolate donut in your mouth, right? And this is because you have a craving for that stuff. You have actually done something against your own will. You know, you made a decision not to do this, but for some reason, you're eating sweets anyway, regardless of your own decisions. And that's the same thing that's going on with addiction, but depending on the substance, at a 5 to 10 times higher rate. So we get that pleasure response, and it's much bigger than, and rather than indirectly affects the nucleus accumbens or pleasure center, it directly affects it. And it's a much, much higher response. So we get all the same chemicals that we're getting from food and sex and all these things that are good for our survival, but at a 5 to 10 times higher rate. So if you can imagine, if you've ever had a craving for sugar, take that and multiply it by 10, and that's what a person's dealing with. Now, at the same time, we can be successful at that despite the cravings. And that happens with our prefrontal cortex. We have a big prefrontal cortex, and we can use that to override these cravings and these instincts that we have. What happens with addiction, with continued use of drugs or alcohol, what we see in the prefrontal cortex is it actually loses mass, so it gets smaller. We see the neurons become disfigured, they change shape, and activity goes way down. So if you've ever seen those pictures of brain activity where, you know, it's all lit up and then it says 8 weeks of crystal meth use and there's tiny little, you know, dots there now, it's because that activity in the prefrontal cortex is going way down. So the system that we have in place to override these urges is being diminished at the same time that these urges are getting bigger. So that's what a hijacked brain looks like. And it is our own survival system tricked into thinking something harmful is good for you. And the reason why we see this behavior, so people will do drugs before they eat. They will do drugs in spite of, you know, losing a relationship. They will do drugs instead of going to work. It's because that instinct is telling them that this is the most important thing that you have to do. So that person is being run by that craving, and they no longer have the ability to tell it no because that prefrontal cortex is now damaged as well. And that's what addiction looks like in the brain. And that's what we're looking at when we see that behavior. And that is why it is a disease. You know, it has that pre-existing condition, and then it has actual physical changes to the brain and the brain chemistry that cause sustained addiction. So opioids, you know, have their own set of problems. We have physical dependence, withdrawal, and tolerance. So, you know, with tolerance over time, you need more to get the same amount of effect because your body is trying to achieve homeostasis and get back to normal. So it's producing its own chemicals to match the amount of opiates that are in the system. And it also has something called receptor downregulation, where it is destroying its own receptors to give the opiates less surface area to attach to. So what that looks like is that person that started with just a little bit is now having to do a whole lot to achieve the same effect. And it usually doesn't even achieve the same effect. It really, if you ever heard anyone say, well, I don't use to get high, I just use to get normal, they're literally using to get normal. They're using to match that chemical level in their body that their body is creating in order to fight the effect of the opiates. And the physical dependence comes because of all those extra chemicals in the system. They don't go away when the opiates go away. So we've still got all these chemicals that oppose the effect of the opiates, and they're speeding everything up. They're putting that person in fight or flight. They're causing muscle cramps, diarrhea, throwing up when that person doesn't have the opiates in their system. And your body will actually preemptively keep making these chemicals in expectation of the opiates going into the system. So when the opiates stop, it's hard for that person to function at all. And that is the withdrawal that we get. The withdrawal is that time it takes for the chemicals to get back to a normal level. And also now that person has been, their receptors have been downregulated, so they don't have enough to function normally. So they're going to be hypersensitive to pain, along with all the sickness that comes from the withdrawal. And what we're looking at with withdrawal is really the body functioning normally, but at an accelerated rate. So that's why we see all the, you know, the shivers and the cramps and all that good stuff going on. I have experienced it. It is not pleasant at all. It's like the flu times 10 with debilitating depression thrown in just for fun. Is what it looks like. So examples of opioids, you know, most of these are pain pills you would get from a doctor. Very effective as pain medication. It mimics the body's endorphins So it attaches to the same receptors. And that's why it's so effective, because anytime you take an opiate from an external source, you get way more than your body would ever give you naturally. But we got things like hydrocodone, morphine, Vicodin, Percocet, oxycodone, Oxycontin, which is the one that started this whole crisis when it was, said in a press release that less than 1% of people would become addicted to it. And it's basically a long-acting Percocet and much stronger. And, studies show 10 to 20% of people have that predisposition for addiction. And guess what happened? It wasn't 1%. It was about 15% of the people that took it became addicted. Doctors started, we remember the pill mills and pain clinics that were just giving it out to everyone. And then we started to see a lot of people die. Once people got wind of this and they put restrictions on the Oxycontin, and people had to go to the streets to get their pills. Very, very expensive. An 80 milligram Oxycontin on the street is $80. That's $1 a milligram, where they were previously paying $6. And, eventually ran into someone that said, hey, here's a little bag of powder. This is $10. And it's just as good. It's going to do the same thing. And those people were able to switch over to heroin to keep from being sick and to deal with their addiction. Then we started to see the death rate increase. Now, what we're looking at, particularly in Shelby County, is fentanyl. And this is not the fentanyl you get in a patch for cancer patients. This is not the fentanyl you get when you're giving someone a colonoscopy. This is being made in laboratories, like clandestine laboratories in China and Mexico, and being shipped over here by the kilo and sold just like heroin. It's at first it started to show up in heroin as a kind of as a cutting agent, make it stronger, make people come back quicker. It's about 50 times stronger than heroin. So you can imagine the propensity for somebody to overdose on it. But now what we're seeing is just pure fentanyl. And people that are using it on the street, they know they're getting it. And also we see a lot of counterfeit pills that have fentanyl in them. So, someone could be going and getting a Xanax pill. That's what they think they're getting. And it's pressed into a shape of a Xanax, but it's fentanyl. So people that have no tolerance to opioids, the first opioid they take could be fentanyl. And we've seen a lot of deaths from people taking fake hydrocodones, fake fentanyls. Very important that we educate people that if they don't know where a pill came from, to not take it, because there is a chance nowadays that it can be fentanyl. And then the last one we have is methadone, and things like methadone, Suboxone. Those are maintenance drugs. Those are opiates, but they are used for medication-assisted treatment to give to, it's a form of harm reduction where people don't have to go out on the street and hustle for money and, all the things that they were doing to stay high on heroin. It's a dose of medication in the morning, perhaps one in the evening, and it will allow that person to, live a much healthier life and to get themselves into a position where they can eventually get off of those drugs and get recovered. So here's the numbers, what we're looking at now. So every day, 130 people are dying in the US. Now these numbers are from before the shutdown, before the stimulus package. So this probably is increased now. But if you look, 67% of those involve synthetic opioids. That's fentanyl. Fentanyl is a synthetic opioid. And so we're looking at a person dying about every 11 minutes in the United States from this. The numbers we've had more people in Shelby County die of overdose than from COVID since the lockdown started in March. More people die from this in car accidents, gunshot wounds. This is the number one killer in the United States today, accidental death. This is the number one cause of death of young people in the United States today. And the CDC estimates it cost our country about $78.5 billion a year. And that's lost productivity, medical costs, things like that. So in Tennessee, 6,052,000 prescriptions of opioids were written in 2018. We've only got about 6,150,000 people in Tennessee. So we're looking at almost a whole prescription for every man, woman, and child in Tennessee. Now, if you look at that and you consider that 10 to 20% of those people have the propensity to become substance abusers that take this, that's a lot of people. In 2018, we had 1,304 people die of an overdose in Tennessee. That's about 20 per 100,000 people. And if you look from 2014 to 18, heroin overdose deaths increased by 150%, and fentanyl-related overdose increased by almost 1,000%. So these numbers are Shelby County. These are the CDC numbers for Shelby County in 2018. They exclude a lot of things based on their criteria. We have a very good reporting system in Shelby County, and the actual number for this was 213 fatal overdose deaths in 18. We had 203 in 17, so there's about a 3% increase. In 2019, we had 341. So it went from a 3% increase to about a 40% increase. And the reason for that, according to the DA's office and the organized crime unit, is the amount of fentanyl that is on the street now. And the potency of it is getting stronger, and we're seeing a lot more of it. So we are on track right now, if things were to keep going as they were, to be close to 600 by the end of this year. So we're looking at something that is progressing very rapidly, and with the and the numbers so high this year would be likely due to the other pandemic and the shutdowns and the inaccessible recovery and isolation and things like that. So what naloxone is it binds to the very same receptors that the opioids bind to, but it has a higher affinity for the receptor. So when the opioids are in the system, they are acting on the receptors. They get on the receptor, they fire it off, and they get off, and then the next one gets on it. Well, when the naloxone comes in and gets on it, it stays on it. So the opioid can no longer get on the receptor. So in essence, it doesn't activate the receptor. There's no intrinsic action on the receptor. So it's basically just blocking the receptor so that opioids cannot attach to it. So the problem, of course, with opiates is that they bind to opiate receptors in the brain. And there's an area in your midbrain that monitors the amount of CO2 in your blood and tells you how fast to breathe based on that. And when that signal gets blocked by too many opioids, rather than maintaining, it just goes down, down, down until that person stops breathing. And we're looking at respiratory failure at that point. And so the naloxone will work very quickly. As soon as it blocks enough receptors and that brain gets the signal back, it flips back on immediately. So that person literally comes back to life at that moment. It does not have the potential for abuse and does not increase risk-taking behavior. There was this idea out there for a while that, we're giving people Narcan, that they're going to be, likely to use more because they're going to get this sense of security. Well, I can just get Narcan. And I promise you, people that are addicted to opiates are going to use as often as they can anyway. It doesn't matter. And it turns out people that are trained in Narcan are more likely to get help than people who are not. They know where to go to get help. And, we have reports every single week of people whose lives this has saved. And sometimes on a continual basis. Sometimes it's the same person 10 times, but then they get into a detox bed. So, the only side effect of Narcan is breathing. So in other words, there's no harm that comes to giving someone Narcan. It will not work for any other substance. So if someone's on took too much Xanax and drank too much, and you give them Narcan, it's not going to do anything, but it will not cause them any harm at all. Having said that, you do not need to know what that person took. So, when I worked in the ER, everyone who came in unconscious got Narcan, first thing. It's not going to hurt them. And if you come along and someone's turned blue on the sidewalk, we're not going to be able to ask them what they took, right? So it doesn't hurt to give it to them. It's one of those things, it's better to use it and not need it. And this is just a crude drawing, I would imagine, of what it looks like with the opioids on the receptors, and then the Narcan coming in and blocking the receptors from the opioids getting back on. Okay, and at this point, I'm going to turn it over to Jill, and she's going to do the actual physical Narcan training.
So on this slide, it's showing you the risk factors for an overdose. Mixing any sort of alcohol or Xanax, Ativan, Valium with it will decrease your ability to breathe. And also somebody that has been in jail, detox, or rehab. I work right now at Grace House part-time as their nurse, and I talk to the women that are there. It's a treatment center for women, and I talk to the women there, even if they graduate successfully. If you can train the families, like Josh was talking about, relapse happens, but I really like to talk to them about the fact that, their ability, what is the word I'm looking for? Tolerance, thank you. Their tolerance is back down to 0. Within supposedly 72 hours, your tolerance goes back down to a normal tolerance. And so, but if you have an addicted brain, which I'm also in recovery and I have an addicted brain, my brain is going to tell me, I've been in jail for 3 days. I deserve to do as much as I did last time, or I can handle as much as I did last time. And they do as much as they did. And either it's too much because they can't handle it, because they have no tolerance, or it's fentanyl and they thought it was heroin, or it's fentanyl and they thought it was a Xanax, or it's fentanyl and they thought it was a Percocet. And like Josh was telling us, the organized crime unit, we work with them, and they've explained to us that the Mexican cartels have literally gotten the actual machines that press these pills. So it is the same pill press that is used. So it looks just like a Xanax bar.
You can't tell the difference.
Yeah, and it just, I have high school kids, and I grew up here, and did a lot of I hung out with the Christian Brothers boys, and we took pills and did things in high school. And the thought of my daughter taking what she thinks is a Xanax or splitting it with a girlfriend, and it's actually pure fentanyl, that's death. That's incredibly terrifying. And in China right now, the reason, Josh was talking about them making it in these labs, no sterility, and they're adding analogs onto the fentanyl, so they're making it stronger and stronger. So even if you think you can handle fentanyl, it might not be the fentanyl that you took last time. So those are.
And that will be the most common one, is when someone's tolerance is down and they use again. That's what we see most often in fatal overdoses.
And using alone, especially men, there are tons of people use alone, but in Shelby County, older men seem to be found alone, dead a lot, because there's nobody there that can revive you. And it's a big risk. Are you going to do my
Yes.
thing? Okay. So recognizing an overdose. I had the great pleasure of having an ex-boyfriend do this 7 times in front of me. So I can tell you what it looks like for sure. He looked like every time like he'd actually been embalmed. It doesn't matter if you're white, black, Asian, you will have blue lips, blue nails. Your pupils will be constricted. If you ever think somebody might be using, their pupils look, it's called pinpoint. They're just really, really constricted. We have here signs of over-medication, heavy nodding. Like if you heard that heroin nod where they just kind of go out like that, come back to, but if they're coming back, it's over-medication, it's not overdose. If you can get them to respond, then, then they might need to wake up a little bit, but they're not technically overdosed. I would like to say this though. If it was my kid or if it was somebody that I was with, they're going to get Narcan. If you can't hurt them. I mean, I'm not going to wait for them to overdose before I use this. So signs of an overdose, like I said, blue lips, blue nails, unconscious, shallow breathing, breathing less than 6 times a minute, pale, clammy skin, loss of color, gray looking, faint or no pulse. You can check their pulse, and extremely small pupils. Okay, what not to do. And I gotta say that these things have actually been done, or they wouldn't be on this screen. This was made by the state of Tennessee, this slide. So people have actually injected milk and salt water into somebody. I don't know even how that can happen. Don't put them in a cold shower or a cold bath. I think that's the most common thing, or pouring water over somebody. And the reason that you don't do that is because they could aspirate. If they swallow it and it goes into their lungs, they could aspirate, and that is a really big deal. They could choke, vomit, and also have the same thing. I have heard of people doing that, and I also have heard of people giving them a shot of speed or crack or something. That also does not work. A cup of coffee is not going to work, especially if they can't swallow. So. What to do during an overdose: try and maintain responsiveness, call their name, shake them, use the sternal rub, where you rub your knuckles on their sternal bone really, really hard to see if you can stimulate them to respond to you. Again, if I have any question, I'm going to administer naloxone. It cannot hurt. If it's a stroke or heart attack, if they're not all the way overdosed, you're just going to remove that drug from the receptor. And like Josh was saying too, nobody does this to feel good. You're going to put them in withdrawal. There are no Narcan parties going on where people try and use and see if they can overdose. That doesn't happen, because if you use naloxone on somebody, you put them in withdrawal, which he explained is, nausea, vomiting, diarrhea, and you waste the $20, $50, whatever, on the drug that you were trying to use. What you do is use naloxone, and so in your kits, which look like this, they are going to have 2 4-milligram nasal sprays, some gloves, the insert to the medication that nobody's going to read, a little card that says, now that you've overdosed. But on the back of it, it has really good resources, some numbers to call for treatment. It's actually got Pathways in Jackson on here too, and a couple of Madison County places if you know anybody that lives in Jackson. But most of these are Shelby County numbers, and just, get some help. And then there's this sheet, which is folded up in there. And when this happens, I worked in heart surgery, and I loved a good code before it was somebody I knew. And when this happens, it's a really scary situation. And so just so you know, if you forget, there's a little sheet inside of the bag that tells you exactly what to do in case of an overdose. And it is the most simple thing ever. There's also one in the back of right behind this, and I'm going to actually peel this off so you can see what you do. So I'm going to use Ben as my example. He was the ex-boyfriend. When he overdosed, hey Ben, are you okay, buddy? No response. I'm going to take him and I'm going to lay him flat, because I am going to do CPR. I'm going to tilt his chin back because I want to open that airway all the way, and also because this is a nasal spray and you want that gravity to work to go down into their body instead of pouring out their nose. So I'm going to grab my kit. If you touch fentanyl or anything, you are not going to overdose. And I mean, it's unless you have a huge cut on your hand. God gave us skin as a barrier. Wash your hands really well if you accidentally touch it. But we have gloves, so put them on. Take the 2 seconds just in case. You're going to take your Narcan. You're going to peel it back. Take it out. It looks just like this. Can you see that? In that middle, you're going to put your 2 fingers like that in the middle like that. Shove it up their nose. You want me to shove it up your nose?
No, thank you.
shove it up their nose to where your fingers hit the base of their nose, their nair. It doesn't matter which nostril you use, and you just push it, and it gives that little dose. And see that middle part, it stayed up. So it's ready to go. It's one dose. You're done with it. Throw it to the side. So you're going to start your CPR. If you're in Shelby County, I suggest if you're by yourself, you use that Narcan first, because you got about 6 minutes before you have brain damage without oxygen. So I would suggest doing the Narcan, letting it start working, and then calling 911. If you're going to do that, I would give some CPR. And if you haven't called 911 in Shelby County, they'll put you on hold. It takes a minute. It's a process. If you're with somebody, obviously have them call. So what did you say? So you start your CPR, and within 2 minutes, really 2 minutes, 2 to 3, but 2 minutes, if they don't start pinking up and, like Josh says, come back to, then you can give a second dose, which is also in your bag. Exact same thing. It doesn't matter which nostril you use. You might not even remember which one you use because it's scary. And just shove it up there and do it again. Keep doing your CPR. You cannot overdose on naloxone. So if you have more bags, or somebody with you has a bag, we have heard of people going, I hit him with 4. Really what that looks like to me is you didn't wait 2 minutes or 3 minutes in between, and you were panic stricken and you just gave more, or you thought more would do more. We've heard that it puts, the more naloxone puts them in more withdrawal afterwards, but we don't know what kind of analogs this fentanyl has these days. So it might take 3 doses. That's very rare. Usually 1 4 milligram dose works. When they come back to, sometimes we've heard of people literally, like Ben, every time he came back, he was breathing, standing up, talking to me, he was back. If they're not, you can turn them on their side, and you can see on the screen, it's the rescue position, their hands under their head. And the reason you turn them on their side is because in case they do vomit, they won't breathe it back in and aspirate. I used to, if he was coming to, I'd scratch his back and, kind of stimulate him to keep breathing. And I'd be like, hey, I think you had a little bit too much. Why don't you take a deep breath for me, okay? You're all right. Be calm, be kind. They're not going to feel very good, going to be scared. He did not ever remember. Obviously, they're not with you during this time. They're not breathing. They're basically dying or dead. So they don't remember any of it. So just tell them kind of what happened, that EMTs are on their way, and that they're going to be all right, and take some deep breaths. And naloxone works for, is it on the next screen? Naloxone works for, these are some other kinds. The Avizia, that's kind of like, it tells you how to do it in the thigh and injects. The injectable Narcan, if you pull it back, you can inject it in their outer thigh. We just have the nasal spray, which is the one that we're gonna give to you. So
Okay.
you don't need to run it.
I think we can stop here because we got about 10 minutes for questions.
Okay. So you turn them on their side, tell them the EMTs are coming. When the EMTs come, you just hand them this and say, they know we're giving it out, and just say, this is, it took 1 dose, it took 2, and it lasts 30 to 90 minutes. If for some reason, a lot of the people that we know on the streets do not call 911, they just do this themselves. You can re-overdose after 30 to 90 minutes. So you want to keep them with somebody and try and get them not to use. Obviously watch for needles. If you're in the Kroger parking lot and you see somebody go out and you know that you can rescue them, please do. But be careful, because people do use needles and stuff. And I guess we'll have time for questions if anybody has questions. And if you need more, we can get you more as well. If you use it, we need to know. So please contact us, and we don't need names. We just need to know the stats and the data so we can turn it in and continue this lovely grant, which is, like Josh said, saving a lot of people's lives, a whole lot of people's lives. And good people, just sick people.
So while Eric's getting queued back up, and people out there can type their questions into the chat if they want. I actually had a couple of questions.
Okay.
First of all, this awesome presentation. Thank y'all for bringing this to us. The kit itself, can it stay inside of a vehicle as far as extreme temperatures and all that?
I was going to mention that. So I have two. I have one in my purse and I have one in my vehicle. No, you're not supposed to, but I would rather have one with me than not. And for men who don't carry purses, I'd have one at home or one in your briefcase and one in the car. But no, it's not supposed to freeze. It's a liquid. Not supposed to get too hot, not supposed to freeze. And it does have an expiration date on the back of it. This one is October 2021. If it were to expire, kind of like a Tylenol, still use it just in case. But we will get you another one, and you can just throw it away after it expires. So
yeah, it's you want to treat it like, you know, most medications. You don't want it to freeze. If it's 110 degrees out, you don't
try and remember.
Don't put it on your dashboard of your car
Yeah.
where the sunlight can hit it. You know what I mean?
So at one point, I know I've spent some time with like it's a group called the Emergency Services Council here, and you know they talk about this issue a lot in their quarterly meetings. This could be as far back as a year ago. There was an issue with not having enough Narcan. Has the grant addressed that, or is that still a concern at all?
Not for our grant.
Not for
We're
us.
actually getting an increased budget for the next round. So we just got another 2 years added, and I think we have more money for Narcan. So if it's coming from us, we should have plenty. I mean, we supply Shelby County Sheriff's Department, Memphis Police Department, Germantown, Collierville, Millington. That's thousands of units just by itself.
I think the data was like in 2019, they surpassed 2018's Narcan use by in April or something. I mean, they basically ran out. And
Yeah, it's increasing across the board. We're also seeing it in communities that we didn't before. You know, this initially started as a white male dominant issue. It's almost parallel with African Americans and whites in Shelby County now, and the highest increase, the highest at-risk group today is Black females.
It's non-discriminatory, and you probably know, like, you know, the flyers, like the amount of panhandlers that we've seen in Shelby County. It kind of decreased with COVID, but now they're coming back. And there's heroin camps, Sycamore View, down under the Madison Bridge. I mean, they're all over. There's camps of children, it looks like to me, but you know, young people for the most part, that are living on the streets that are, I mean, families have given up on them. They want to be out there too, because they're so sick. They're so run by this illness. Can't get away from it. But we really have, with the needle exchange, been able to help a lot of people. Yesterday we had a guy waiting for us when we went to set up that went to treatment. So, well, we hope we got him in treatment.
Yeah, they don't always stay,
Yeah,
but you know, not the first time anyway.
Yeah.
I'll keep hoarding the questions, Eric, until you tell me to stop. Is there, would a doctor's office normally have this in their office, or is that something they need to specifically act on and request?
They need they can get it and go. You can get it over the counter at any Walgreens, Kroger, anywhere. It just costs. For us, it's a free service that we provide, but you know, they should have it. They probably don't, but they should have it along with their first aid kit.
Yeah, the main goal of this program is to get it to underserved or uninsured, you know, nonprofit businesses, things like that. The way for a for-profit that is having difficulty with corporate getting, you know, Narcan to give away, the way around that is we will actually go and train the clients, say at an MAT clinic that's corporate, you know, that doesn't have Narcan. We can go do individual trainings with the clients and make sure that they all have Narcan, or they can specify a day where they can all come and we can do it as a group. So we'd be training that person directly.
But we have trained dental offices and doctors' offices for sure, a lot of them, along with every type of business you can imagine is, you know, Starbucks, people are falling out in the bathrooms, McDonald's, it's everywhere. Sadly.
One question I think our audience submitted was whether or not there's any potential harm or side effects with certain patient types, specifically pregnant women with unborn babies. Any issues there?
It's the only person that can't have this is a 0 to 28 day baby whose mother was using, because if they go into withdrawal, they can have a seizure and it could cause brain damage. Otherwise, if your 4-year-old gets into some narcotics, if a pregnant woman isn't breathing, that baby isn't breathing either. So she needs to go directly to the hospital, but definitely she needs some Narcan. And there are pregnant women using out on the streets right now. They are our most at risk, and we need to get them to care.
Yeah, they do recommend immediate observation because that baby will be in withdrawal, and that's what's harmful. It's not the Narcan itself, but like with a neonate, like she said, the withdrawal symptoms can be fatal.
Yeah,
sure. Another question, as far as any new group or nonprofit that needs to reach out to you guys or would like to have training for this, do they just reach out to you directly, or what's the best way to do that?
Yeah. You can do that. I don't know if you have our information available to show, but we are not in the office currently. We work at a St. John's church, and the church is still closed because of COVID. So my phone number is area code 850-333-0435.
Here, I'll put it in the chat.
Okay. And you can call us directly, and we'd be so excited to come and share our information. And when we're doing individual trainings, we can cater it to much shorter, depending on the group we're training to. We wouldn't share all that information about the brain and everything. They don't need to know all that or want to know all that, but so we can tailor it to.
Yeah, an individual training is a layman's training. It's much different.
It's like 5 minutes, showing them how to shoot it up their nose and what
Did
to
I
do
spell
next.
my name right?
No, we can't see it. It's W. Right. Nope. Stop. Yep. W. No, you're going to delete it. Hold on. Move.
I got it.
Okay.
I'll tell you what, we will plan to make sure that we get the information, how to contact you guys as part of our information on our website. So anyone that needs that information, and do remember this has been recorded and it will be available afterwards on the website. So
Okay, I put our phone numbers in the chat.
okay.
Thank you guys. We appreciate it.
Thank you so much, Jill, Josh. Great presentation. Appreciate you coming out today and sharing with us. So again, everyone, thank you for joining us today. We look forward to hopefully getting closer to normal soon, and be on the lookout for more information about our upcoming meetings in September and October. Thank you. Have a wonderful rest of the day.